It's time to get going. I just want to, it's recording now. So I just want to, let me just put the PowerPoint on. Okay, you're all set? Yeah.
That's why she get.
I'll wait till you close the door.
That's fine.
Hi, Rosanna.
Thank you. I winged it. I don't make coffee, I only make tea.
Hi, Donna. I had to find the unmute.
We probably should be unmuted.
Good afternoon, everybody.
Good afternoon, Peter.
How's everybody doing? Can everyone? Not working. Yeah. The light's on.
Yeah.
Okay. Anyways, everybody take their seats. We're going to get started on time. We have 3 guest speakers today, incredible speakers. We're very, very fortunate that I consider them as part of our family. So without any, I know you don't want to listen to me. So what I want to do is introduce, I truly believe, is the top MS specialist in Canada. I want to introduce Dr. Bruno.
Thank you so much. I'm very delighted to be here, and I feel very privileged to be chatting with you today and hopefully answering a few questions if I can. Many of you know me. I am a specialist physician in multiple sclerosis rehabilitation, and I have my main appointment at the University Health Network, Toronto Rehab Institute, and I'm also cross-appointed at the Barlow MS Center at Unity Health St. Michael's. I'm really excited to talk to you today about MS in 2025 because we have come so far. And I really debated whether or not I would give you a sweeping history of multiple sclerosis. But then I thought, you know what, better to leave time for questions than to bombard you with didactic information. I realize that the microphone is not working. So if at any time you're finding that my voice is too soft, please let me know. And if there are any issues with people who are coming here virtually, please also describe that in the chat so that we can adjust. Thank you also to those who have joined remotely. So of course, like any speaker, I do have some disclosures, but I think that none of the items that are on this list are really going to negatively bias what I talk to you about today. So I have a couple of objectives. By the end of this talk, everybody here and online should at least be somewhat familiar with the proposed revisions to the McDonald diagnostic criteria and understand a little bit why this is such a big deal and why it matters so much. Also, to have some familiarity with the current approaches to reducing progression independent of relapse activity. And this is important for everyone at every stage of MS. And then I'm just going to give you a little teaser about MS rehabilitation guidelines and that initiative. So how are we going to go about doing that? I'm going to give you an MS 101 review. I think it's important that we understand the key foundational points about multiple sclerosis as we currently understand it, because there's been such an evolution and such a change. Of course, you may know some of this information already, but it doesn't hurt to kind of reinforce it because that's the foundation from which we're going to discuss all of the other points. Then we'll talk about updates in the diagnosis, like I said, updates in the treatment, and I'll leave you with a few take-home points. So many of you have heard this definition multiple times before. It is a chronic inflammatory / immune mediated, because those two words have slightly different meanings, along with a neurodegenerative component with features of autoimmunity, meaning the body attacks itself, and it manifests, it shows up in a breakdown of the outer coating of nerves, which is demyelination. And that happens in gray as well as white matter. And as a result of the repeated exposure to demyelination, there is secondary axonal damage. To refresh your memory about neuroanatomy, the neuron is a cell that has a cell body, and it has a long axon process with a little button at the end that can release chemicals called neurotransmitters. The way it gives the signal to the end to release those chemical messengers, which tell the next cell what to do, requires the propagation of an electrical signal. And that electrical signal is made much more efficient by insulation, and that's the myelin. The myelin itself is made by a separate cell called the oligodendrocyte, and it's the proteins on that myelin that get attacked a lot. And then when that degrades, the underlying axon is very vulnerable. Also, when that's taken off, the electrical signaling is not so good anymore. And so transmission is inefficient. So under good conditions, maybe you get the signal to go through. Some of those good conditions could be being in a cool state. But sometimes when the conditions are not favorable, that signal does not go through, and that can interrupt the entire neural network of what the body is trying to do. So you get eventual cellular death. And when you drop off your neurons in your brain or your spinal cord, and these are the targets for multiple sclerosis. We're not talking about the peripheral nerves in the arms or the legs. We're talking about the brain and the spinal cord, which is the central nervous system. That's a problem because you need a certain critical mass to be able to do your daily organic functions. So there are a lot of newly or more recently understood processes that go along with MS, which include a prodrome. Now, we're still trying to refine our understanding of prodrome, but this is sort of what's happening, lurking behind the scenes prior to a person presenting for medical attention because they're concerned they have a problem. And of course, right now, we're understanding this prodrome in hindsight. So if we look at chart reviews and we see, oh, these are the patients that have confirmed MS. What was their health like 5 years before their diagnosis? What was their health like 10 years before their diagnosis? Well, there's already inklings of stuff. Some of it is very subtle. Well, we know part of the mechanism of MS is something called the blood-brain barrier disruption. Our brain, our spinal cord is kept a little separate from everything else because it's so important. It really is important. And I don't want to make it sound more important than the heart or the liver or the kidneys, but it's pretty darn important. So it's protected. And so very few things are allowed to cross that barrier. But if you make that barrier leaky, then especially immune cells can cross over, and then they can start to attack structures within the brain and the spinal cord and cause the damage. So now we understand that the cells that cause the damage come in basically two flavors. There are cells that come into the brain and spinal cord from the periphery. Those are chiefly the B cells, the T cells from our white blood cell system. And then the cells that live within the brain and the spinal cord and never go out to the rest of the body. And that would be considered the compartmentalized cells. And the main principal actor, but not exclusively, is a cell called microglia. And it's kind of like a B cell. It kind of comes from the same kind of line, but it lives within the brain and the spinal cord. Interestingly, it's a cell that looks kind of amoeboid, has lots of these little tendrils and tentacles, I'll call them, and it can actually move from one place in the brain to another place in the brain. So you've got actually stuff moving around in there, not just the electrical currents, and I find that kind of fascinating. Astrocytes also live in the brain and the spinal cord, and they are the cells responsible for scarring. They're actually responsible for like a laundry list of activities And I'm not going to go through them today, but one of the things that they do is that they create ultimately the lesion, the MS lesion. So in the past, we have divided MS into different types of MS, relapsing remitting, or secondary progressive, or primary progressive, or even relapsing progressive and benign. And we're thinking more that this is much more of a continuum. These labels may be a little bit more artificial than we thought in the past. They're still useful, they're still helpful, and principally for organizing research trials. So a picture is always better than 1,000 words. And this is the picture that I have shown many of you before, even some in clinic with me. But this really tells it as it is currently understood. MS is a continuum between inflammation, so let's say an attack or damage produced by the self, and neurodegeneration, which is a decay and a decline of the cellular structure, and ultimately the death of that cellular structure. And every person from even before the official diagnosis is made has some contribution of these two things. And depending on a person's genetics and depending on a person's other comorbidities and depending on a person's age, and again, multiple different factors, the split of this is going to be different at any one point in time. So not everybody follows the same split. And so this is the new concept. Progression is therefore very important for people who are newly diagnosed with relapsing remitting. And the concept of relapse and relapse-associated worsening can be important for persons who've already been labeled primary progressive or secondary progressive, and hence why we have some disease-modifying treatments that persons categorized in those labels can actually receive at this time. And of course, it's an ever-changing moving target, and now things are accelerating. The changes between, oh, I don't want to date myself to when I went to medical school, but let me tell you, the change from medical school to residency, and then the changes from residency to practice, and then the changes in the past 5 years have been like astounding. And it's like the curve is going like this. This is the most exciting time, in my humble opinion, to be involved in MS research as well as MS care. Now, I understand it's challenging to live with MS, but from a science and a care delivery, this is like exciting times. So hopefully you will get excited about that too. So when I'm talking about relapse and relapse-related worsening, I am addressing the pathology that our currently available drugs address. And not too long ago, and I'm going to say, 2017, 2016, 2017, we thought you deal with this, you're done. You basically have a cure. You're almost as good as a cure if you deal with this. And it wasn't quite so simple based on the photo, the diagram that I showed you before. But this is a really important, and now we have pretty much shut this down with our current treatments. So what happens? Well, there are chemical messengers called cytokines that drive an attack on a cell or a cellular structure, or they can do the opposite. They can kind of help with repair. They're signaling messengers. And what happens is that in MS, there's an off balance, an off kilter of the cytokines that are pro-attack, pro-inflammatory. And remember, we evolved to have these things because we need to fight viruses, we need to fight bacteria, we need to fight parasites, we need to make sure that we recognize a cancerous cell and get rid of it. So these are immune mechanisms that are important mechanisms for our survival, but they can kind of go a little wonky. So in MS, you have an upregulation of interleukin 12, tumor necrosis factor, interferon gamma, And these can exacerbate disease progression. We also have other things called lymphotoxin alpha osteopontin. You don't need to know the specifics, but that there are multiple targets for future treatment. Pregnancy is protective. Why would pregnancy be protective? Well, you're carrying another life form that has completely different protein structures and different genes. So you better tolerate that well. And so that's why you have to kind of down-regulate your attack. The unfortunate thing is when people have the delivery in that early postpartum period, that's a very vulnerable period for getting the multiple sclerosis attack. Even the first attack, that's a really common time frame for it. Now, you can get relapses in the brainstem, which is a very vital structure that connects most of the larger brain to the spinal cord. So everything kind of has to funnel through that. There are also a lot of innate brainstem functions that relate to maintaining our vital organ systems like breathing, for example. And you can have attacks in the spinal cord. Again, a very small real estate space, everything packed in really tightly. So everything matters. And if the relapses actually happen there, there's a higher predictive value of eventually transitioning into this secondary progressive phase that we're going to talk about a little bit later. And if you don't treat MS with the current therapies, if you look at historical data from when we didn't understand MS so much and didn't have these therapeutics, you could anticipate that worsening would occur in 50% of patients. And usually you could cite that from time of diagnosis, about 50% would need a mobility device at 10 to 15 years and maybe a wheelchair at 20. These were the kinds of prognostic pieces of advice we were giving patients when I was training. So one of the well, I'm not even going to say it was a late great breaking news. It really dominated the Copenhagen ECTRIMS meeting, which you so kindly helped me attend, as well as MS Milano the year before, is this concept that the earlier you initiate treatment of the relapse pathology, so our current DMTs, the earlier you start, the absolute better it is prognostically. It changes the trajectory of the curves even for the progression. So by being aggressive with relapse and relapse-related worsening, you're actually doing a good thing for progression independent of relapse activity as well. And what we learned from especially the Ocrevus type trials is we learned that if you delay treatment, for whatever reason, maybe there are really good reasons to delay treatment. I'm not saying that all delays of treatment are unnecessarily unreasonable, but if you do it, the curves never catch up. You're continuously on a different curve. And so this is why earlier and earlier and more aggressive treatment is being really looked at in a lot of jurisdictions. And there's an actual debate. Should people with radiologically isolated syndromes, and we'll talk a little bit more about that, but you can kind of get a hint from the name that it's radiological. It's just from an image. It's not from how the person's feeling. It's not from a neurological exam. They're feeling fine. Their neurological exam is normal, but they've got stuff in their brain and their spinal cord. Should we be treating that? And a lot of people think yes. So moving on along. So that's the relapse part. And now we have the other part, the progression independent of relapse activity. Remember, some of this is happening even from day one or maybe even before day one in that prodrome. And it's what is sometimes referred to in the literature or in discussions as smoldering inflammation. And in Milan, one of the key visuals with the posters that they had all over the city to advertise that there were like over 10,000 delegates at this conference was a match with like a flame burning out and kind of like the coals. And I don't know if that was the best image, but that's one of the images that they had. So what do we mean when we talk about progression? Well, we're talking about a period of continuous worsening of neurological impairment. Right now, it's over a period of 6 to 12 months, but this is kind of arbitrary. Actually, the state of the art is looking at trying to collapse this to as short an interval of time as possible. Because if you can capture potentially that someone is on the trajectory of ongoing progression, maybe you can do something about it. Maybe you can intervene. Maybe that intervention is a drug. Maybe it's not a drug. Maybe it's more rehabilitation. So trying to capture this progression earlier is very relevant. But for now, let's keep it at this definition of kind of 6 to 12 months. And remember, this is without having had an intervening relapse. This is without relapse. So I already gave you that statistic of untreated relapsing remitting leading to secondary progression in 50% by 10 to 15 years. But we also have to take into account disability progression. And disability progression does not necessarily mean disease progression. They're related, but they're not synonymous. So is it possible that physiologic deconditioning can set a person back tremendously, and then with enough attention to reconditioning, they can bounce back? Potentially, yes. And it really depends on where a person is on that disability trajectory. A lot of researchers feel that once a person gets to an EDSS of 6 and certainly 6.5, that at this stage of the game, that's an irreversible marker. But it doesn't mean that you have to continue down that trajectory, but it's probably really hard to go back. What does that mean? It means that if you haven't reached that level of expanded disability status, that you can maybe go backwards. I see hands, and I'm wondering if, sure. So in terms of what we think at this point is like a milestone of progression, where maybe you cannot after that return to less impairment, less disability, and that would be probably around EDSS of 6.5. 6.5 means you require bilateral support for ambulation, and 6, you're relying on at least unilateral support for your ambulation, in loose terms. So one of the things that will be a take-home point is that what drives relapses and relapse worsening, and what drives PIRA, which is the short form for progression independent of relapse activity, they're different things. They're actually different sets of mechanisms. And this was really kind of encapsulated or highlighted really well with some of the BTK inhibitor trials that I'm going to talk about in a few slides. But they're different. They're different processes. So what are the mechanisms involved? Well, you have things called chronic active lesions. They have an inactive core, and they have an outer edge with demyelination due to macrophage activity. And they slowly expand, they slowly enlarge. They are responsible for what is seen on higher level MR images as paramagnetic rim lesions. Then you have these things called meningeal lymphoid aggregates. They are very, very, very close to the surface of the skull and the surface of the spinal cord. And they are probably what generate the immunoglobulins that people can test with a lumbar puncture. So you've heard of oligoclonal banding, probably comes from these structures, which are not clearly shown on MRI. They're more a pathological finding. But they're responsible for the demyelination that happens just right underneath those covering layers. And then, of course, you have neurite damage. So what's a neurite? Neurite is everything that's not the cell body. It can include axons, the bouton, the little dendrites at the top of the cell body that interact with the other cells in the network. And the damage that comes from those can actually be a positive feedback cycle for PIRA. So damage begets more damage. And this is why, in part, MS is now considered a disease of aging. Because we know as we age, and especially after certain key milestones, which are felt to be biological age 40, biological age 60, biological age 80. I say biological because you could be chronologically 60, but biologically younger, or you could be chronologically 60 and biologically older. But those are key hallmarks for tissue damage. And so basically, what do we want to do? We want to reduce the damage. We want to reduce the damage from the natural processes of aging. We want to reduce the damage from any comorbidities we have. We want to reduce the damage from stress. We want to keep our body as young as it possibly can be, especially our brain and our spinal cord. We want to keep those cells as young as they possibly can be. And that will help slow down PIRA. So this is another one of those like speaks volumes. On the bottom line, you have MRI disease activity with enhancing lesions. So there's been a disruption of the blood-brain barrier. You've got like cells going in and doing their damage. Then on the red line is disease burden. That's like how many regions of the brain and spinal cord have actually been affected. Then you have the clinical disability, which shows that there's a preclinical phase. That's the prodrome I was talking about. And something's probably happening there where no one recognizes that it's happening unless they get a scan for another reason and they have a radiologically isolated syndrome. But then you start to have little attacks. Some of the attacks you heal from perfectly well. As we age, we don't heal as well from the attacks. And if the attack is very severe, we don't heal as well from the attack. And so as we get attack over attack, we accumulate disability, which is an impact on our ability to carry out our activities of daily living. And then we cross a threshold where it just continues. And maybe some of us still have the occasional relapse. And that's where people with SPMS might be on Mayzent, might be on Siponimod, might be on a drug because they might have a little bit of that. And then, of course, throughout all this, brain volume is declining. Now, note, again, all of us have declining brain volumes. That is part and parcel of human aging. But in MS, when you have damage to cell structures, the loss of the cellular structures is at an accelerated rate. So we want to try to make this as level as possible. That's what we want to do. That's our goal. So what else affects disability progression? Depression, anxiety, other mental health issues, cardiovascular comorbidities. These are huge. These are big. High blood pressure, cholesterol issues, having had, heart attacks, strokes. These are big. And then also chronic lung disease can also be particularly important. And we know Ruth Ann Mary and her team, they did quite a lot of work on comorbidities. And if you take two groups, one group has vascular comorbidities, the other group doesn't, and they're matched for all the other characteristics that they should be matched for. The people with the vascular comorbidities, they advance to needing that unilateral support 6 years sooner. That's a huge number. That's a big length of time, and that really can have impact on a person's quality of life. Okay, so who's getting MS today? Well, there are over 90,000 Canadians who are living with MS. That's roughly 1 in 400. Almost 12 persons per day are diagnosed with MS. The average age of onset is creeping up for unclear reasons, but the average age is about 43. And roughly 2/3, 3/4 are female or assigned female at birth. 90% will be diagnosed as relapsing remitting at outset. So what are the risk factors to actually acquiring MS? Well, we know that having the Epstein-Barr virus at critical periods of life between 10 and 40 in particular is the necessary but insufficient cause of multiple sclerosis. So you have to have that as a precondition. But clearly EBV is a ubiquitous virus. And even many people who have infectious mononucleosis, which is what a kind of a severe form of EBV infection, not everybody with infectious mono gets MS. So there have to be other things. And of course, there are genetic contributions, and there are things that make a person more pro-inflammatory to begin with. Some of that is being exposed to more adipokines at critical periods of life. What are adipokines? Those are the pro-inflammatory chemical messengers that are produced by fat cells. So that's where adolescent or childhood obesity comes in as a risk factor. And then smoking or combusting and inhaling any kind of particulate matter irritates the lung lining. The lung lining is in close proximity with all those blood vessels and the blood that's traveling because it has to pick up the oxygen. So if that lung is irritated, then the whole body is exposed to inflammatory products. That's why even smoking 1 cigarette per year is enough to put a person in a pro-inflammatory condition. You really, really, really want to not irritate your lungs. And this, in Copenhagen, they talked a lot about environmental pollutants, and they talked about the risk of MS in centers that have really, really poor air quality. And it's different, it's higher. You live in a city that has poor air quality, your risk of MS is higher than if you live in a pristinely wonderful rural area that has the freshest air ever. There's also some contribution from vitamin D metabolism, and some of it is vitamin D exposure, and some of it is actually exposure to sun. So exposure to sunlight is not synonymous with vitamin D, believe it or not. So there are things that sun gives a person that is more than vitamin D. We just don't know what all those things are, but you know, it is important to have some access to sun. We were talking about windows in offices, like those are important. The microbiome, the kind of cells and bacteria that live in symbiosis with us, that's really important. There are differences in gut microbiota between persons living with MS and those who don't live with MS. And again, probably mediated through the inflammatory cascades. And then physical activity. So physical activity can produce the counter effect to what is pro-inflammatory. And we are understanding more and more that exercise is really a disease modifying treatment. We're nearly there in terms of like putting it on big banners, but the people in this field, they're very convinced. They're very convinced, and we're working towards that. Now, I put a question regarding head injury. It's still a little bit controversial. It's looking at like some increased risk may accrue if there has been previous damage through injury. So MS is a disease of, MS is a diagnosis of exclusion, meaning that you still have to make sure that what you're dealing with is MS, and you rule out things that could possibly be mimicked. So again, we're getting very good at doing that. And how we're doing that is through looking at other antibodies that might be around that attack parts of the brain and spinal cord that are not related to the EBV, not related to the cascade of things that happens in MS. I'm thinking of the things like the neuromyelitis optica spectrum disorders. There are vasculitides, some of which can come from other autoimmune diseases like lupus. There are hereditary conditions, especially spastic paresis or cerebellar ataxias that need to be ruled out, some of which can be ruled out through genetic testing. But by and large, MS now is diagnosed with MRI. And we're going to talk about that. There is still some role for potentially evoked potentials in a lumbar puncture, but MRI is it. So when did we start to have MRI access? This is interesting. MRI was introduced in 1981, not that long ago. And it took a few more years to get gadolinium, which is an enhancing agent. So that's a tracer that allows us to understand where there's been disruption of that blood-brain barrier. So even back in the 1980s, when this technology was coming to the fore, radiologists recognized that there was ongoing progression in between attacks. And that just highlights the time lag between figuring something out and really understanding it well. And I guess it just didn't get picked up that much. But it's interesting because now there's all this curiosity about that. But what MRI really did was helped confirm that there were lesions in space. So when our nervous system is developed, there's lots and lots of redundancy, meaning multiple different areas can do similar things. But there's usually an area that does it really, really well. And so we have parts of our brain that say are responsible for producing language or understanding language or moving the body. And it's very specific. We have parts of the brain that are really good at moving the arm versus moving the leg. And we have different pathways that, obviously talk to each other. But as part of how MS was diagnosed before we had access to images, you had to have different body regions affected, and you had to have them affected over time. So you couldn't just have this one attack. You had to have a second attack at the very least. What MRI revolutionized is they could actually show with the use of the tracer that yes, different parts are involved. And guess what? This lesion's younger or older than the other lesion. So they could actually show the dissemination in time as well. So that was huge. And so these criteria became very important for diagnosis in 2001. And then as we understood more and more, and as MRI technology became better, because with the stronger the magnet, the more you can resolve in the brain and the spinal cord. And we developed newer sequences with the help of computerized digital systems. So we got different sequences and we got better scanners, and we've had to revise these criteria over time. And there are new revisions for 2024. And this was probably the most exciting thing that was discussed in Copenhagen. Or a couple of other exciting things too, don't get me wrong, but this was really important. And because making a change to the criteria involves, it has many downstream effects. It has downstream effects at the level of radiology and diagnosis. It has the downstream effects of, well, what are you doing with the information? There's lots of downstream effects. So right now, they have not been fully cemented in a publication. I can't say, go and read X. It's coming. It's evolving. But the highlights, and I think I'm going to skip over really what the original McDonald criteria were. I'm going to skip over that just in the interest of time. These are the kinds of things that MRI picks up. These are lesions around the ventricles that light up. You can see, I don't know if I can use this. Will that go? Will that track? No, it doesn't track on there. But over there where there's an arrow, you can see rim lesions. So there's lots of different types of lesion findings that you can see on these. But what I want to highlight are the proposed changes, okay? So never before did they have the ability or the resolution to actually use the optic nerve to track lesions. The optic nerve is so tiny. It's so tiny, but now they can. And so they can use sequences that can look at the optic nerves and they can see if the optic nerve is affected. So that can be part of the criteria. They also have looked at adding biomarkers to be an adjunct to the MRI images. And so if you have certain MRI images and you have these biomarkers, which you can do serum neurofilaments, which are like a breakdown product, for example, of nerve damage, then you can kind of use them together in tandem to say, oh, yes, we've got something here. Then there are imaging markers like the rim lesion that I showed you, or a central vein sign, which again is something that you don't need to know the intimate details of, but these are things that are newly captured now, newly understood, and they can be pointed to. And if you have a certain number, then you reach criteria. So this is the most important part of the 2024 changes, without having to know the specifics, without having to be a radiologist. Okay, the most important part about these changes is a person who gets a scan for any reason and has certain findings can be diagnosed with MS, even if they have a neurologically normal exam and no symptoms. So, radiologically isolated syndrome with dissemination in space can fulfill MS criteria without clinical signs if you have 6 central vein signs or dissemination in time, so you have lesions that look older or younger, or if you have biomarkers, which are from a blood test or an LP. So this is huge. This goes back to what I said before about how important it is to be diagnosed early. The earlier you're diagnosed, the better your outcomes. And in fact, the prognosis for people who are diagnosed with MS today is not the prognosis my patients had when they were diagnosed 20 years ago, is not the prognosis my patients had even when they were diagnosed 10 years ago. This is good news for all people who are diagnosed now. And all of this information, no doubt can help and will help down the road everybody living with MS. It's just a matter of how we can implement this knowledge to make changes. We'll talk a little bit about where the future lands in a bit. So there are a couple of other benefits, and this is why it was such a big deal. So what do the changes in the criteria mean? They mean earlier diagnosis, and I've hammered that home. They mean increased accuracy. So the misdiagnosis chance is reduced. Potentially fewer tests. Maybe, with one scan, you can get a heck of a lot more information than you could before. So you'd have to be in that scanner fewer times, which I know a lot of people don't like being in it. It's very claustrophobic for some. And it's a much more comprehensive evaluation. And, there are still some caveats. Nothing is going to be perfect in medicine. And even with the tightest criteria, you're going to have false positive rates. You're going to have false negative rates. Age and other factors like comorbidities do need to be taken into account. It becomes harder and harder to tease out the difference between what is a stroke-like change, something called microangioplastic change, and what is actually demyelination. So if you, put someone in a scanner and you give no demographic information, you give no clinical information, and you just look at those scans, sometimes it's hard to tease out, is this stroke, is this demyelination? Can be really hard, really hard to do. So you need that context and you need the age, etc. So all of this to say, we have a better handle on what MS is. We have a better handle on how to diagnose it. So do we have a better handle on treatments? I think we do. We're not exactly there yet, but we're making great strides. First of all, we're making strides in disease modification. And I'll show you a list of DMTs that really have made a huge impact in relapse rates, as well as relapse-associated worsening. We have multiple new symptomatic management strategies as compared to where we were, say, even in the 1980s and in the 1990s. We have a much better understanding of how exercise, mindfulness-based stress reduction techniques, and even nutritional and water optimization can improve a person. And there's a greater acceptance in the field of the importance of interdisciplinary approaches to care. So not just having the neurologist, but having multiple specialists and multiple allied health personnel involved on a regular basis with persons living with MS. That's so important. And what are the future approaches? Well, the key will be helping poorly myelinated tracts to become better myelinated, preventing cellular death, so keeping cells alive longer, and maybe helping with enhancing neural networks. So this is a list of what is currently available in Canada at this point in time. And I have to say that the anti-CD20 therapies like ocrelizumab, they're super powerful. They're extremely potent. They essentially decrease relapses to almost zero. I'm not going to say they're zero, but it goes down to a very, 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 very low annualized relapse rate. The new drugs on the horizon, for which in the US, there are some FDA specialized requests to kind of fast track analysis, come from a class of medications called Bruton tyrosine kinase inhibitors. And I've highlighted the one that has the most interest in it at this point in time, and that's called tolebrutinib. And also in Copenhagen, in the late great breaking news, they came out with the preliminary main results. Well, they're not preliminary. They were the main results. It's the preliminary presentation because all the subgroup analyses were not yet complete. But in the tolebrutinib trials, which were compared to teriflunomide in both the relapsing and the secondary progressive MS patient cohorts, showed improvement in rates of disability change. Now, tolebrutinib was effectively equivalent to teriflunomide in terms of efficacy for relapses and annualized relapse rate. So it was not better. So it actually failed its primary endpoint. It's not better than teriflunomide, and teriflunomide is a great drug, but it's not ocrelizumab. So that was somewhat problematic, but the fact that it showed that the group that was taking it didn't accumulate as much disability at 6 months was a huge deal. Huge enough to get the makers, I won't give them a plug here today, although I don't think your group is as strict as at the universities, but that they've gone to the FDA in the US and they said, please fast track this for assessment because we want an on-label indication for MS. Because these drugs have been designed for B-cell cancers and other lymphoproliferative disorders. They're cancer drugs, but they've been repurposed. So yes, we have many Bruton tyrosine kinase inhibitors in Canada presently being used for hematological cancer care, but we don't have anything on label. So no one can get it outside of a clinical trial right now. So there are a couple that will have some data at the end of 2025 and some into early 2026, where the comparator is actually ocrelizumab. And so that's going to be really fabulously interesting for me to know where they stand. Some people were discussing after the late great breaking news, in the roundtables, well, could it possibly be that you give a BTK inhibitor and you give a relapsing active DMT in combination therapy? And that people got really excited about that. Maybe that's possible. Or maybe the side effect profile with working on the immune system to that degree might be problematic, or maybe the cost would be prohibitive. Who knows? But at least it's getting people to think about how are we going to manage care to address both sets of pathologies that are relevant in MS. So this is a huge paradigm shift. This is a really big deal. A lot of studies, especially at the animal level, have happened with looking at remyelination enhancers, but there's really nothing on the horizon yet. There really is nothing. And in fact, I was quite disappointed when I was at the meeting in Copenhagen because I attended the only session on remyelination, and it was all wet lab. It was all bench science, and there was nothing to really report to you guys in regards to clinical. And part of the reason why it's so tricky to remyelinate or to repair is that innately we have a lot of inhibition to growth or change in our brain and our spinal cord because they're encased in a hard space. You've got the skull and you've got the spinal column. So you do not want dysregulated growth in a tight compartment. And so we've evolved evolutionarily all these restrictions on what can happen. Now, if things happen outside, not so much of a big deal, you know, your immune system kind of gets rid of it, but in the skull, it's a little bit more challenging. So just the take-home points from Gemini 1 and Gemini 2, because I thought you might be interested in this. They cross the blood-brain barrier, these BTKIs, so that's really important. So they address things in the periphery, and they address the microglia. They have microglial targets. And there are a bunch of different ones that have different binding affinities and penetrance into the central nervous system. But they basically inhibit the function of a protein enzyme that is important in B cell and microglial development, maturation, and signaling. And they do so by adding phosphate to specific amino acids in proteins. So I already gave you the highlights of this. I won't repeat it. But there are a couple of caveats for tolebrutinib. At the 60 milligram daily dose, it often elevated the liver enzymes quite substantially. And in some people, it elevated them dramatically to kind of life-threatening levels. So very, very frequent liver enzyme monitoring has to happen with these medications. So that can be somewhat problematic. There were a couple of unexpected findings that need further exploration in the secondary analyses. So I'm not going to dwell on them, but the most important one was that there weren't any clear results with respect to brain volume between the two groups. And that was found to be surprising because brain volume is our surrogate for progression in many respects. We automatically assume that if there's atrophy, there's been worsening in progression. And so this was kind of confusing because you had no clear difference between the atrophy, but then you had a clear difference in their clinical disability. So it was a bit bizarre, but we're waiting on more analyses to better understand that. And I already told you that there's a priority review given by the American FDA for tolebrutinib based on these findings. So what are the treatments of the future? The treatments of the future would be Epstein-Barr virus vaccines, not necessarily to give to absolutely everyone to eliminate EBV infection, but to give within the context of MS to modulate the activity of Epstein-Barr. Remember, when we get a virus, that virus stays with us. It just is kept kind of quiet, but we can still find EBV residing and harboring in some of our B cells because it infects B cells. So vaccines might be important there. We know about neurofilaments. Well, there may be a number of other biomarkers that can actually help kind of track how a person with MS is doing at any point in time, and maybe that can inform changes in care. Then with the use of artificial intelligence, we might be able to have such huge amounts of data that we can then say, this person needs this treatment at this time. And that's what we're kind of hoping to do with AI. And then we're hoping that people will have more access to rehab because rehab will be important as people age no matter what. And again, improve symptomatic treatments for things like spasticity, for neuropathic pain, for neurogenic bladder, for mood changes. There's a number of improvements that could be made there. And then, you know, people are still working on a cure. This is still something that a lot of research dollars go into. One of the take-home points at Copenhagen was the end of a very lengthy, very well-designed, large, it's effectively randomized controlled trial looking at simvastatin, which is a dyslipidemia agent. It's an anti-cholesterol agent. And for many, many years, it was being given as a neuroprotectant in people who didn't even have high cholesterol. And unfortunately, that was negative. So basically, there is no reason to take that drug unless you need to treat your cholesterol. You need to treat your cholesterol for sure. It's going to help. But if you don't have cholesterol issues, there's no point in prescribing it. And so the recommendation is do not use it off label. And that was a really big announcement that was made. So what to do now? I think this is actually the most important slide of the presentation. If you're eligible for a disease-modifying treatment, my strong suggestion is really lean hard towards taking it. I mean, you've got to have a really good reason not to take the DMT. Exercise. Exercise is disease modifying. Move whatever you still can move. And if you have to imagine doing exercise, there's value in that as well. Virtual exercise, imaginary exercise is powerful. It overlaps with mindfulness-based stress reduction techniques. And we know that those increase the ends of the telomeres, which are the caps of our DNA, which are the internal biological clock of the cell. So as the telomeres shorten to a particular length, that's a signal for the cell to turn off and to apoptose or die in a controlled way. The longer your telomeres, you push that further out into the future. So exercise mindfulness can do that. So virtual exercise can also do that. And treat all your comorbidities. Do not let the rest of your health slide. If you have high blood pressure, be aggressive to treat it. If you have other health problems that are taxing your system and causing your system stress, get them under control with the appropriate providers. Don't let it sit. Don't ignore it. Falls prevention. Falls can be disastrous. They can be the difference between functioning at a fairly good level and having a good quality of life and being sometimes bedbound. And that can be the difference with one fall. The more times you're falling, the higher the probability of something being catastrophic, either in terms of head injury or in terms of a broken bone or a major sprain strain. And anytime the body has to put energies into tissue healing, it's taking those energies away from compensating for the MS deficits. And this is why, if any of you here or in the audience have fallen, you may know that around the time of your big bruises or any other trauma, you're not feeling your greatest, and maybe you have more spasticity, or maybe you're running to the bathroom more. Like there are a lot of different things, or maybe you're even delirious. Pace yourselves. Don't burn the candle at both ends. Use whatever environmental adaptations or compensatory strategies you can to get around impairments that are irreversible. And please continue to socially engage no matter at what level of impairment you're at. Social engagement is important for overall wellness, and it's definitely important for cognitive preservation. And cognitive preservation is so important for being able to direct your care. So this is my teaser. What can we look forward to besides more DMTs? And more DMTs are coming. Trust me, they're coming. Can't tell you when, but they are. We are working on a rehab guidelines initiative. I am doing this with colleagues, Dr. Mark Bailey, Catherine Knox, Sarah Donkers, Robert Simpson, and a whole group of transnational stakeholders from different areas. That includes specialist physicians to allied health, to persons with lived experience, and to policymakers. So this is a really exciting project. It is fully underway. We're going to be looking at a range of impairments and activity limitations guidelines. And we're hoping that this creates benchmarks, very clear benchmarks for care provision and targets. And it can basically push health systems to provide the care, so increase the access to rehabilitation. It may also help provide the information to providers that don't have a lot of facility with treating persons living with MS in underserviced regions. So it can act as a resource to them. And we're hoping that all of this crystallizes within the next 2 to 3 years as we have funding for this project. And so you should stay tuned for further announcements. This is on the horizon and it's very exciting. I'm very privileged to be a part of it. I have references on the slide deck, but basically that's it. I want to thank you for your attention, and I'd be very happy to try my hand at any questions. Any questions from the audience? Okay. we'll take the front and then we'll take the back. So go ahead.
Just wondering why sterifluoride they give as a reference.
Well, because it is safe for most people. It's easy to take for most people. It's an oral agent. Tolobrutinib was an oral agent. So there was some, you know, blinding and matching and placebo control. So I think that was part of it. And they wanted to use something that had relatively lower efficacy to show that it would have higher efficacy, but it didn't, unfortunately. But I think, you know, I wasn't involved in the design of those clinical trials. This is my best guess as to why they use that agent. But again, there are some against ocrelizumab, which, you know, that's a really high bar to meet.
This comes from more of a personal experience that I had, and I could only associate it with something with MS. It's happened a couple of times, kind of scary when it does. It's happened, I put away the dishes all the time, and I was doing my regular routine, and I had dishes in each hand. And I wanted to put this in that container. And I couldn't convince myself to do it. I mean, this is something that I'd always do and couldn't do it. I was frozen. And so what I did, put it down, and just had to shake my hands and then get my sort of bearings back again and then continue. I'm wondering if you ever experienced anything like that or heard anybody?
So the first thing I'm going to say is, because I am not your provider, I'm going to strongly recommend you discuss that with your treating neurologist or your primary care physician. But there is something called apraxia. Apraxias can happen. I've seen them sometimes in MS. They're sometimes more common in stroke, where there's a loss of doing a particular motor pattern. So there's a challenge in getting the motor pattern to be done with the voluntary command. So there's like the person wants to do the command, but then trying to get that motor pattern to happen is really hard. So sometimes I might see that with a patient where I'm telling them I'm giving them a command in terms of a physical examination maneuver, and they understand, cognitively, they understand the command. They know what I'm asking them to do. So it's not a comprehension issue, but they cannot get their body to do what I'm asking them to do and what they're asking their body to do. And so there's a disruption there. Now, I can't say that's what's happening in your case, but it makes me kind of think about that. I think it would involve more exploration. But one of the things that I can actually suggest that you think about with those episodes, if they ever happen again, is, are you overheated? Do you have an infection? Do you have any other stressor going on that might be making your system not work around the lesions that you have to the best of its ability? So I would question that. And I would basically see if you could address that right then and there, or at least look into it right then and there. I hope that's a satisfying enough answer. Go ahead.
You just mentioned stressors, but if you're in a situation with chronic stress, we all know that can precipitate a relapse. But how, I'm not sure how to say it. I mean, I know there's the ability of the person to be able to respond to that stress affect how relapses go.
So I'm going to take a stab at it. So resiliency factors are really important. And so someone who may have more resiliency factors might dampen down the impact of the stress on the biological system. Someone with less resiliency factors or fewer resiliency factors might not be able to do so as much, and the scales might be tipped over at a certain point, and that can manifest in a problem. But every single person can improve their resiliency factors, no matter where they're starting from. And some of that can be done through things like mindfulness-based stress reduction techniques, either working on breath work or listening to even 10 minutes per day of guided meditations. Exercise can improve things like that, can be a counterbalance, because when we're under stress, we have a certain hormone profile, we have a certain kind of fight or flight going on, and the exercise can be a counterweight to that. Things like gratitude journaling, things like supportive counseling, things like some cognitive behavioral therapy, fresh air, nature therapy, talking to a friend, peer support. These are all things that can be helpful to make a person be able to buffer the stress, because all of us have stress sometimes that we cannot escape. Life will give us, we can't escape tariffs, for example. Right now we can't. I don't know if we're going to be able to. I know that's causing a lot of stress for a lot of people. But, you know, there's literally things that you can, you know, if you have a sick family member, that's not something, you know, you're going through a divorce, that's not something that you can escape. So there will be tough times, but there are resources to kind of giving yourself a little bit of a boost. And it would be important to do so. Yeah. Go ahead.
I love swimming. Anytime I'm in the pool, I feel I can conquer everything.
Excellent.
I would like to swim every day,
Wonderful.
and I'm wondering, there's also the need I've been told, right? But you should also use more like land exercises.
Okay.
So what?
Great. Okay. So
But the other thing is, in walking in the pool, I am touching the bottom of the pool. Is that enough?
okay.
Or do I still have to do that land exercise?
And this is such a great question.
You're welcome.
And anybody who's my patient knows that I love swimming. And anybody who's my patient knows that I feel swimming is the best of all sports. Okay. They will know this. Swimming is phenomenal, and pool walking and aqua fitness, they're phenomenal for your cardiovascular fitness targets. They are great for myofascial pain control, because you're moving all of your muscle groups in a really big degrees of freedom. And so if you're sitting at a chair all day, a desk all day, and you know you're in one prolonged posture, being in that pool environment can allow you to be in different postural arrangements. That's really, really great for myofascial pain. This also has a corollary to chronic widespread pain, which is more central, and it can mitigate that too. So there, and I could go on and on and on about scapular stabilization and spine. I can go on for a very long time about the benefits of swimming. What swimming will not do for you, nor will pool walking do for you, is improve your bone health. In fact, people who are really avid swimmers or really avid cyclists, specifically talking about the cyclists that are going on the road, they need to make an effort to do some weight-bearing exercise to decrease the rate of loss of their bone. So if you can do standing throughout the day, even with support, that can help be that extra antidote that you need. So it's not that you necessarily need to do a lot of land-based, but you do need to have some gravitational forces through the axial and appendicular skeleton to keep your bone mass up. And that's really important. And along with that, you have to take into account having the appropriate vitamin D and calcium environment for the bone to stay strong and move, because bone remodels with force lines. So all that you do is be in the pool environment and sit, that's not great for your bones. Go ahead.
Thank you.
You're welcome.
Dr. Bruno, this is awesome. But very transparent. I'm overwhelmed with the amount of information. My daughter got diagnosed in 2022. And in the middle of, in the early 30s. But she got connected with St. Michael's Hospital. So she is being treated by an amazing doctor who got her rapidly onto the medication. She is, she was concerned about getting pregnant, not wanting to get pregnant. But today I'd say that she is pregnant
Congratulations.
and we're expecting our first granddaughter.
That's wonderful.
So, thank you, God, for that. And I love the fact that you shared that, concluded that while has this child within her, the child is protected. She's all.
Absolutely.
On that note, you did mention, and that is something that Victoria was always very concerned, the relapse.
Mhm.
How bad can that look? Can you give me the worst scenario? And I will just take that worst just for my own sake, to know there is a
So rather than go down the route of what is the worst case
Yeah.
scenario or what might happen, what might not happen, the fact that she is under the care
Yes.
of people at that center who are so expert and so attuned and so understanding of these trends, they will be on top of it to make sure they mitigate that transition. So part of mitigating that transition will also have to take into account your daughter's desire to nurse or not nurse. So there will be a slew of options that are given to her, and she'll be able, I'm sure, to make an informed decision based on her values and her appraisal of risk, right? So what's important to her and what are the chances, etc. So, I mean, I think that if her main priority is I want complete coverage after I deliver, they can, I'm sure, make that happen.
I have a second point. Thank you for addressing exercise, and I agree with the aquatics. Exercise is such a big component, no matter what we're under. That definitely, and weight bearing exercises is something that I know with her too. Like if she's not able to stand or whatever, if that was the case, just getting those weights. I think that's what you're saying will still give her that land.
So
is that correct? Like if someone can't stand,
mhm.
is just sitting in their chair and doing those weight training.
So weight training in seated exercise will help the muscle group that is being trained. So if there are upper limb resistance training exercises being done, that's going to be very specific to where the benefits are going to be. So for someone who cannot stand at all, sometimes there are ways to do that within select environments, community physiotherapy, etc., where you can actually be in a standing frame and you can be helped into a frame and stand for a period of time where you're secure. Obviously, help is needed to get in the frame, help is needed to get out of the frame, but things like this exist. So there are options. Some of my patients have even made the investment of having such a device in their own homes. But there are, and I could give a whole additional talk. Maybe one day you want to invite me back for a talk on exercise where I talk about all the principles of exercise, including the specificity of training. So one of the things that my patients have heard me say a lot is if you want to walk better, you got to walk. There's no walking better with swimming. There's no walking better with cycling. There's no walking better with elliptical. You got to walk. And so that means even if it's with the walker and it's just on level terrain and you're thinking about walking while you're doing it, that's what needs to be done to maintain that ability. There's very little cross training.
One last part was the microbiome. There's a whole talk it's like coming out there. The connection, because we know that the neurons are in there.
Mm-hmm. Yes, we do have we do have
so is there any,
a brain in our gut.
Exactly. So I'm just wondering, is there studies as well on that in relation to
many. And an old mentor of mine, his name is Amit Bar-Or. He is like so elegant when he speaks about this topic. He is probably the person I love to hear the most speak about the gut microbiome. Very complicated, not 100% understood. Huge body of literature on this. And, I don't have a good sort of bullet size statement of, this is what everybody should do. But I do think that having staying away from ultra processed foods is the single most important thing you can do to improve your microbiome, period. And then, of course, further improvements require understanding the person's individual biology and their health history. So I can't, beyond that statement, I won't go further. But ultra processed food is a disaster to the microbiome. So please avoid it as much as is humanly possible.
Thank you. Thank you, Dr. I just want to have a quick question. You mentioned MRI, and the importance of that, and that you noticed that if you have an individual who is not able to have an MRI, what's the other option?
That's a fantastic question, because there are some people who have objects in them that preclude it, or there could be other reasons. There is no equivalent technology. Of course, we can image the brain with CT, which is high dose X-ray radiation. And of course, you can use CT plus evoked potentials, plus lumbar puncture, plus, potentially biomarkers, serum biomarkers to kind of get a picture of things. But it's not going to be equivalent. And unfortunately, until they change the technology and they make it so that it's not using a magnet, it's going to be challenging for some people. Now, there have been hurdles in the past, like body mass index. There have been hurdles in the past, like claustrophobia or fear. There have been hurdles in the past of having implantable devices. Usually there is a scanner in the GTA that can accommodate people at higher levels of body mass index. Usually there will be a scanner, a facility that might even entertain anesthesia for really, 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 really important adult study. They use anesthetists or anesthesiologists to put children to sleep a lot for surgical planning. It's not so common in adults, but for some select procedures that could be considered very high stakes. Usually high stakes means you've got a cancer and you need to treat that cancer in a particular way. But for most implantable devices now, there are usually ways of either turning off the device or mitigating the device in some way so that the person can go in safely. Not for everything, but people are working to make sure that these devices either have a very good shut off, like a baclofen pump. You can have the baclofen pump turned off, and that, all the components of the baclofen pump are done so that they're safe within the scanner, that kind of thing. So that's the best I can answer that one. I just wanted to double check, are there any questions from the virtual group that I need to address before I continue with the crowd here? I don't have a way of knowing from my computer setup.
There's nothing in the chat.
Okay, perfect. Okay, great. So happy to take another question then.
No, I was just gonna ask,
Okay, go ahead.
no, I was gonna ask like also like with MRI, like is a PET scan also beneficial like to find like other illnesses in conjunction with them?
So PET scans are very, very, very great technologies, especially for looking for cancer. I am not familiar with PET scanning literature in MS. So rather than even take a stab on it, I'm going to have to profess my ignorance. What I can tell you is that in Canada, we have very, very, very little access to PET. So it would not be relevant in our clinical environment for MS at this time. That I can say fairly confident.
I'm just wondering, in terms of increasing circulation, I have little things to work with, but I'm wondering, there's sometimes there are things that you can stick to your body that increase circulation. Does that make sense, just what I'm talking about? And the importance of that and increasing your, hopefully increasing the ability for the connectivity to happen.
So I'm not particularly familiar with devices that have high levels of evidence to help with that. I know you can get vibrating platforms. I know you can maybe even get some home functional electrical stim. You know, there are things that somebody will sell you. I'm just not certain that the impact will be substantive. Use at your own risk is what I'm gonna say.
Yeah, sure, but there's no research being done to see.
That's not where the bulk of the direction is right now in MS. So that's really a good question. So in my own practice, I try to make a plug for no ultra processed food or as little as possible for quality of life and a well-rounded diet. And I say to my patients, if they can cut out sugar, like simple sugars, power to you, because sugar for sure can definitely be problematic. And it can be problematic at a metabolic level, and it can be problematic in terms of a blood flow and circulatory level. It can even have pro-inflammatory effects. So if you can get rid of sugar that you don't need, by all means. The dairy piece is a little bit more challenging. It's a tougher one. And I think the reason why people are not automatically saying no gluten, no dairy, no sugar, and being very prescriptive about it is because we do not have the highest level evidence available to be able to make those statements with full scientific rigor confidence. So there are, of course, people who cannot tolerate gluten, who are gluten sensitive or have celiac disease. And of course, they should minimize or perhaps even eliminate gluten. There will be people who are lactose intolerant or who have other issues with dairy. Some people actually have allergies to components of dairy. So if you're a person that has some very specific issues, you may also need to limit or reduce. But I think that looking at it as a full population, the entire population needs to do this, this, and this. There's not enough evidence to suggest it at this time. And I think that's where people are a little bit more cautious. So what they are saying is you should have a normal vitamin D serum level above 75. I like to target 125 nanomoles per liter. That's something that is legitimate. You need to have normal vitamin D. You should have a B12 level of above or at 300 picomoles per liter for optimal neural health as well. So there are some things that we really know, and for what we really know, we really say them. For the things that we don't really know, we hold back, and we really have to make your own decision there.
There's 3 questions online.
Okay, so how do I know what they are? You're gonna have to tell me what they are. Thank you, Ian.
No problem. Let's just minimize that. Oops.
There we go.
And we'll go to the chat. Can we change the main screen up? They wanted to see you speaking.
Oh, shoot.
So what we can do is just end the screen share right now, and you can let's just end that. And we'll do screen 1. And now people will see you.
Can people see me now? No, but I don't see me. But can you? Oh, can you hear me? Hi. I so thought you guys could see me. I had no idea. But now I have an echo. There's interference.
The echo will go away in a moment.
Okay.
So, any other questions in the room?
Okay, one more question.
I even that too, I just recently heard that mono connected to MS, and I'm just perplexed because I'm thinking, I got mono and I was out cold for a while, and I wondered if that would trigger. But I'm just curious the connection.
Yeah, so Epstein-Barr virus causes infectious mononucleosis. The more severe the infectious mononucleosis, the higher the risk of developing MS later on. So Epstein-Barr virus is considered the causal necessary factor for MS. So it's the basis upon which MS eventually comes. But it's not just having the infection. You have to have other hits to your system, including, a genetic predisposition. So what happens is the Epstein-Barr virus has some protein structures on it that look very similar to what we have in our central nervous system. And so when our body's immune system tries to attack the virus, it's producing antibodies that are effective against the virus, but they're also antibodies that kind of latch on to parts of our central nervous system, especially myelin basic protein. And so then it tells the immune system to get rid of that myelin because it thinks it's a foreign object. So it's complicated, and there is multi-layers to it. And people presume that, like, if the EBV exposure happens under age 10, it's not that big of a deal. And if the EBV exposure happens after age 40, it's not that big of a deal. But in between 10 and 40, that's when your immune system is really supercharged, and it can kind of be a little too forceful against the EBV, which also ends up harming its own person. So, but it's not a simple thing. That's why the EBV research is ongoing, and there's lots and lots of EBV research that's presented at these annual meetings, these international annual meetings. They're still very, very avid investigations, and a lot of questions remain about how much EBV plays presently in a person living with MS, like what contribution of that virus inhabiting the body is still relevant. So that's still up for debate, and we're still getting to know more about it.
Is there's a study that a layperson can read to get a sense of?
I wonder, I don't have anything to suggest right off the top of my head, but I'm wondering if going to MS Canada or the National MS Society or the UK MS Society web pages might give you more information, because they might even talk about the US Veterans Study, which is a huge seminal study that was published a number of years ago that basically laid to rest this idea. I mean, we've been knowing about EBV and MS for more than 2 decades, but it was really cemented home by the big Veterans Study, which basically corrected for many other confounders. Yeah. I saw one other, and we're going to make this probably the last, because I know that there's lunch and I know that there are other speakers, so I don't want to overstep, but I'm happy to answer this one last question. So it's been around for many years. Yes, it has been around for many years. And again, the decision about which particular disease modifying treatment is best for any one individual has to do with many different things, including disease severity, disease activity, the age of the person, the comorbidities, the preferences they have on how they can take it, some of the remuneration, the cost and payment of the drug. So it's kind of and so I wouldn't be able to give you more information than that, but it's been around for quite a while. Thank you very much for your attention. I really appreciate being here. Take care. Bye-bye to everybody online.